Thank you, everybody, for joining. We're very excited to have Dr. Rebecca Hubbard with us today. Dr. Hubbard is the Carl Kawaja and Wendy Holcombe Professor of Public Health and Professor of Biostatistics and Data Science at Brown University. Her research focuses on development and application of statistical methods for studies using data from electronic health records and medical claims, including issues of data availability and data quality, and has been applied to studies across a range of application areas, including oncology and pharmacoepidemiology. She's a fellow of the ASA and co-editor of the Journal of Biostatistics. So just before I turn it over to Dr. Hubbard, two quick housekeeping notes. Everybody, please, if you could turn your cameras on, since we're fully virtual, then at least Dr. Hubbard could have some smiling, floating faces. And feel free to ask questions throughout the talk. You can use the Zoom raise hand feature or the chat, and and I'll keep an eye on it. And so without further ado, Dr. Hubbard.
All right, thank you very much. It's lovely seeing all of these smiling, floating Zoom faces. So I'm happy to be here with you. And yeah, please feel free to ask questions throughout. I've got the chat open, so I'll try to keep an eye on it too. But yeah, let me know if there's anything I can be clearer about. Especially, I think in this talk, I'm going to be presenting some of my research looking at patterns of healthcare utilization and how that informs our ability to use electronic health records to do research, and in particular, thinking about the implications that that has for data quality and differential data quality across different populations that have different access to the medical system. So I tend to think of my research as being quite interdisciplinary and being situated sort of at the intersection of biostatistics, informatics, and epidemiology. But I am a biostatistician by training and by outlook. So if I get into any kind of like statistical jargon that you're not sure what I'm talking about, please let me know so that I can be clearer. And also, if my slides aren't advancing, if it looks like I'm still on my title slide, let me know that as well. That's an issue I sometimes have with Zoom. So on this slide, I have a depiction of the learning health system, which I would imagine many of you are familiar with. It's a concept that's become really popular in recent years. At this point in time, almost 100% of the administration of healthcare utilizes electronic health records. So through the EHR, we have access to this big resource of data that we can use to do research to learn about which interventions work best for which patients and what their outcomes look like. So the idea of the learning healthcare system is this sort of closed loop where we take the data that are generated through routine administration of healthcare. We conduct research on that to try to learn about what works best. That's the evidence part of this diagram. We then take our learnings, put it back into practice in the healthcare system in order to improve the way that patients are being treated. That generates more data. We use those data to do research, et cetera, and we end up with this cyclical process where healthcare should just be getting better and better because we're constantly learning about how to do things better and how to treat patients more effectively. So this is a great idea. And when we think of ourselves as researchers, and particularly as statisticians, and I think also as informaticians, I think where we would tend to position ourselves in this figure is somewhere between the data, the end of data, and the evidence and the beginning of practice. So we're taking the data that come out of the EHR, we're conducting research in them, and then we're generating some kind of results that we're going to turn over to clinical collaborators who will then put that evidence into practice. So I think if we localize ourselves too discretely within the evidence portion of this diagram, it's really limiting and I think potentially gives rise to misleading research results because the other two portions of the figure, data and practice, should really inform the way that we're conducting that research. So in this talk, what I'm going to try to emphasize is firstly that we can't just do research in a vacuum. We need to think carefully about where the data came from and what systematic biases, errors, and inequities may have led to data quality challenges in that data that are going to influence the way that we really should be conducting the research in order to get to valid results. And then also at the output side, we need to be thinking about how the evidence that we're going to generate will be used in practice, because the way we do the research and the answers that we give will be different depending on how the results are going to be used. My talk today and a lot of my research is really grounded in thinking about the EHR data provenance process. And from a statistical perspective, when I think about EHR data provenance, I immediately think of differential data quality. So by data provenance, I mean the process that gives rise to the data from the EHR that we have available for research. And it's important to keep in mind that these data were not generated out of thin air. They're generated through the process of patients interacting with the healthcare system. So on the right-hand side of this slide, I have a figure that depicts the way that I think of the EHR data provenance process. And in particular, I have this illustrated as a triangle because I think of it as a funneling down. At the bottom, we have the EHR, the stuff that we're going to find there, be it structured or unstructured data, or administrative data that's necessary for the administration of healthcare. But in order to get into that record, which we're going to use for research, a whole series of steps have to have happened, each of which is going to limit in a different way the data that we ultimately have available to study. So I imagine that out in the real world, there's an enormous population of patients who meet the inclusion-exclusion criteria for any study that we might want to conduct. But we don't see all of those patients. We only see the ones who actually present to the healthcare system and receive care. So whenever we're conducting research with EHR data, the very first data quality issue that we need to grapple with is selection bias. The data that we see are not necessarily representative of the broader data that would be available if everyone had equal access to healthcare. So there's a selection bias issue. In addition to selection bias, once the patient's in receiving treatment and in the healthcare system, the patient and provider have to address the condition or conditions that are of relevance to our research. So we know that not all patients receive the same kind of care. There are all sorts of reasons that different patients receive different tests and procedures and medications. Some of that is just to do with their health. So because we're using health records to do research, that means people with more healthcare needs, people who have more chronic conditions, for instance, are going to get more healthcare. They're going to have more tests, they're going to have more procedures, they're going to have more medications. So we're going to have more data available for them. We also know there are all sorts of reasons that don't have to do with people's health that influence the type of healthcare that they receive. And I'm thinking of things like health literacy, access issues related to, for instance, insurance status. And then there are all sorts of biases in the interactions between patients and providers, that just arise from our society that lead to different people receiving care that looks different. So the amount of data available and the type of data available is also going to vary enormously across patients. All of this tends to happen in a very clustered way where different healthcare systems, different clinics, and different providers tend to have different practice patterns that generate data that looks different. And then we have patients nested within those units. There are also all sorts of reasons that information just falls out of the EHR, right? So things actually have to be documented in order for us to be able to study them. I tend to think that anything that is necessary for clinical care to be delivered is going to be recorded relatively well. Anything that's sort of optional or discretionary is potentially not going to be recorded well. For instance, I'm going to give a few examples from oncology, and I've done a lot of research in the oncology space where we find that in the oncology EHR, conditions that inform the cancer treatment a patient is going to receive are recorded quite well. Conditions that could be things that are very serious, like a stroke or a heart attack, but that don't directly inform choice of cancer treatment are not necessarily going to turn up in the oncology EHR. So there's lots of information that's just going to be lost due to lack of documentation. So at the end of the day, what we end up with is a very heterogeneous record. It looks different across different patients, and in particular, patients from historically vulnerable, medically underserved groups will have poorer quality data because they have less interaction with the healthcare system. And when they do interact with the healthcare system, they're going to have fewer tests and procedures and medications due to all sorts of reasons and access challenges. So with that in mind, in my talk this afternoon, I'm going to present 3 different projects that I've worked on that kind of center around these issues of differential data quality due to the EHR data provenance process. First, I'm going to present a project that just highlights the challenge of informed presence bias. I'm going to raise this as a potential issue that we need to worry about. I'm then going to show you an approach to addressing this issue using a quantitative bias analysis framework. And then finally, I'm going to discuss implications of this same challenge, informed presence, for algorithmic fairness when we're using risk prediction models for tailored healthcare decision making. This first part, which is really just kind of consciousness raising to help people recognize the potential impact of this challenge, is work that was led by my former doctoral student, Joanna Harton, and was published in JAMIA a couple years ago. This is a figure from that paper, or part of a figure from that paper, illustrating the kind of information that we have available in the EHR. So this is a strictly hypothetical example. We're imagining that we have 5 patients who are illustrated with the different colors here, and each patient has a biomarker that we would like to measure. This is the value that those biomarkers take over the course of 2 years, and we're assuming that this is something that evolves in real time. So each day the patient gets up in their body, in truth, they have some kind of a biomarker value. If we take their EHR data and we use their EHR to try to assess what that biomarker looked like, we might get something that looks like the figure on the right. So the left is kind of the biological truth that's going on with these patients. The right is what we derive from the EHR. You can see that there's a correspondence between these 2 things, but since we can't measure the value of this biomarker in real time, we're only able to update our information about the value that the biomarker takes when the patient makes a visit to the healthcare system. So we see this kind of chunky, discrete realization of these curves that are actually much more volatile. If we break down those 2 curves, those 5 curves, we can pull them apart into 2 different sources of information. So when we look at the EHR, what we see is that periodically the information about this biomarker is updated. But it turns out that those updates take 2 different forms: informative visits and non-informative visits. Informative visits are visits that are prompted by the underlying health condition itself. So imagine that the biomarker is related to something that produces a symptom. So when the patient's biomarker value is high, they feel bad, or they feel in some way that they know they need to seek care. And so they go in, they get their biomarker measured, maybe they get treated. And so we tend to have more information about the biomarker when it's elevated, because something about that elevation is prompting the patient to seek care. So those visits that are driven by the value of the biomarker itself, we call informative. We also imagine that in the background, there are visits that are unrelated to the value of the biomarker. So in this strictly hypothetical population, I have a patient population that is highly compliant with a recommendation that they come into the clinic every 3 months. So every 3 months, regardless of the biomarker value, we see the patient, and therefore we're able to take a measurement and update the biomarker. So if we put these 2 pieces of information together, the measurements from the informative visits and the measurements from the non-informative visits, we get the trajectories here on the right. And so you can tell that we end up with altogether more information and kind of a more detailed measurement of the biomarker process when it's elevated versus when it's lower. So there are a couple of reasons that using data that's generated through that kind of process leads to bias. And in this paper, we conducted a simulation study to try to illustrate the magnitude of bias that results from using this kind of informatively observed data. and also to try to illustrate sort of when you need to be concerned about this and when you might be able to get away with being less concerned. So let's imagine we want to estimate the association between the biomarker, which I'm going to call B, and some kind of a health event, Y. So B is evolving in real time, and specifically we are simulating it so that it follows a random walk where the step size from day to day has variance sigma squared. So if sigma squared is big, then we have a very volatile biomarker that's changing a lot from one day to the next. If sigma squared is small, we have a pretty stable biomarker that pretty much just holds constant over time. We additionally have a patient characteristic H. I'm calling it H because I like to think of it as family history. It's something about the patient that's going to be related to the value that their biomarker takes and also is related to their probability of making a visit to the healthcare system. So imagine that patients who have H equal 1 are those with a family history. They tend to have elevated biomarker values, and they also have kind of heightened awareness of their health conditions, and so they're more likely to make a visit to the healthcare system. Everybody makes non-informative visits, uniformly observed with rate lambda. I'm just going to show you results for one value of lambda. In general, the results are insensitive to what value we choose. And then they also make informative visits. So these are visits that are prompted by the underlying biomarker value itself. And we assume that on a given day t, the probability that they make a visit on that day, v sub I t equal 1, is proportional to the value of the biomarker. So if it's high, they're more likely to make a visit, and also related to that underlying characteristic H. So if they have H equal 1 on a given day, they're more likely to make a visit that day as well. The outcome of interest is going to be related to our biomarker and also to their characteristic H. So I'm going to show you results for how much bias there is in our estimates of that parameter beta B. So that's the target parameter because it's telling us about the relationship between the biomarker and the health outcome as we vary the magnitude of beta B itself, and also as we vary sigma, that step size in the biomarker from one day to the next. In this figure, I'm showing you the bias in beta B across the three plots as we vary the magnitude of beta B. So from a small association, odds ratio of 1.1 to a strong association, odds ratio of 1.5. Within each plot, on the left, I have small step size in the random walk. On the right, I have a large step size. And then the four methods that I'm comparing are if we somehow had oracle information on the value the biomarker takes in everyone for every day. So those are the green box plots. Scheduled visits are just the non-informative visits that everyone makes according to the same rate of visiting. So the blue box plots are based on just analyzing the non-informative visits. The red box plot is based on just analyzing the informative visits, and the purple is based on putting them both together. So in practice, in the EHR, we usually can't distinguish which visits were informative and which visits were non-informative. So the purple is most representative of what we would be doing in the real world. So my first takeaway from this figure is the left side of each plot where sigma equals 0.2. You don't see a lot of bias regardless of which approach you use. So if there's not much volatility in the underlying time-varying characteristic that we're interested in, it doesn't really matter. This problem is not of much concern. So if I were doing a real analysis and this was something that I'm considering, that's sort of the first thing I would think about. Is this a pretty stable characteristic where I can just take a measurement of a patient at any point in time and it's going to be highly correlated with all their other measurements? Or is it something that really fluctuates day to day, so I need to be able to trace it more carefully? On the right of each plot, I have the more volatile trajectory results. And here we see, first of all, the magnitude of bias is proportional to the strength of the effect itself. So if we have a null effect, if there's truly no relationship, if beta B had just been log of 1 or 0, then it doesn't really make a difference because all of our results are going to be pretty close to 0. As the magnitude of the effect gets larger, the bias is magnified across the different methods. So just looking at the far right-hand side where beta B equals log of 1.5, what we're seeing there is obviously if we had all the values, we would do fine, no problem. If we only have access to information from scheduled visits, we see pretty substantial attenuation towards the null. So I think that surprises people because they think, oh, isn't that what you would be doing if you did primary data collection and you had like scheduled clinic visits for everybody? But in fact, here you get significant attenuation towards the null because of measurement error. So everyone has this very volatile trajectory, but we're just infrequently updating it based on these discrete visit times. So you end up with a rather poor realization of what that trajectory looks like. If we only use the informative visits, we're going to see positive bias. So in this case, this looks like bias away from the null. In fact, it's positive bias regardless of which direction the true effect was. And if we look at all the visits where we put together the informative and non-informative visits, we get something that's in between the two. So I think uh, one inclination that people have when they see this result is to say, okay, the purple result is sort of balancing out the bias from the blue and the red, so maybe that's a reasonable thing to do. Unfortunately, it's not that simple because in this particular case, because of the direction of the associations that I've simulated, the blue and the red biases go in opposite directions. It's also possible if I'd reversed the sign of one of the associations in my simulation model that both of those biases would go in the same direction. And so the purple would be even worse. So it would be magnifying the bias rather than balancing it out. So the moral of the story is there are two different biases at play here, one due to measurement error and one, as we'll see coming up, due to collider bias. And we can't get around those two sources of bias just by analyzing all of the visits. To illustrate what this looks like in a real data set, I used data from the Children's Hospital of Philadelphia, where we asked a really simple, rather naive question, which is just, is low BMI in kids associated with pediatric mortality? So we had about 70,000 kids who had made at least 2 in-person visits to the Children's Hospital of Philadelphia Health System. And if you look at these data, just empirically, what you'll see is that patients who died had lower BMI z-scores at their first observation than patients who survived throughout follow-up. And patients who died tended to have more BMI measurements over the course of follow-up. So altogether, it looks like there is potentially an informative observation thing going on here, where maybe there's a negative association between BMI and survival, but additionally, kids with low BMI are being more intensively monitored, so we have more information about what their BMI looks like. So as I mentioned a couple minutes ago, in EHR, we usually don't have information about which visits are informative and which are non-informative. As a proxy for that, in this data set, we're able to divide the observations into those that come from outpatient encounters and those that come from emergency department and inpatient encounters. And we reasoned that emergency department and inpatient visits are indicative of some sort of a health challenge for the child. So ED and inpatient visits pretty much have to be informative in some sense. Whereas outpatient visits, because kids have a pretty intensive schedule of well-child visits, outpatient visits could potentially be non-informative. So when we look at these data, the way that I interpret these results are if we look just at the outpatient visits, which tend to be or are more likely to be non-informative, we see a significant negative association between BMI and the hazard of death. So the hazard is decreased in kids with higher BMI. If we look just at the ED and inpatient visits, which we have reason to believe are likely to be informative, we see significant attenuation towards the null. So we see an effect that's much closer to 1, is not at all statistically significant. And if we put those two together, we see something that's a little bit in between. It's still a negative association, but it's no longer statistically significant. So I think in these data, what we're seeing is that measurement error plays relatively less of a role. The outpatient visits results, I think, are more likely indicative of the truth. And then we're seeing bias introduced by incorporating the ED and inpatient visit data, which were informatively observed. Of course, it's impossible to say for sure. So that's my hypothesis based on what I think is going on. But at this stage, I've just raised this as a challenge without a solution. So what I'd like to talk about next is a more formal way of trying to think about these two different sources of bias that arise due to this data provenance challenge, and coming up with a way to formally, quantitatively account for the magnitude of that bias and decide whether or not our results are robust. So to get a little bit more precise in talking about these two sources of bias, the issue with using the EHR data that I'm raising is that, one, there's potentially differential and or dependent misclassification of EHR-derived measurements due to that different depth of information for different patients. And then two, there's collider bias that results from conditioning on utilization intensity. I'm going to say more about that coming up. So let's imagine that we're interested in quantifying the strength of association between an exposure X and an outcome Y. In this part of the talk, I'm going to envision that my exposure is diabetes, so whether or not a patient has diabetes, and my outcome is whether or not the patient experiences cancer progression or death. And this is in the context of a cohort of patients with a personal history of breast cancer. So we want to know the relationship between X and Y. Here I have made X and Y red because we never truly observe either of those. We're going to observe imperfect EHR-derived proxies for them. So XO is going to represent an EHR-derived exposure measure that represents but is not perfectly concordant with diabetes. This might be something we come up with based on a phenotyping algorithm. It could be very simple, like looking for a diabetes ICD code. Similarly, YO is going to be a misclassified proxy for our outcome of interest. In the data set that I'm working with, we have a variable called real-world progression or death. So this represents whether or not when we look at the EHR, we can deduce that the patient experienced cancer progression based on, for instance, something that appears in a physician's note. We also have a vector of baseline covariates Z. I'm going to assume that they're measured without error. That's probably not a great assumption, but that introduces a whole nother level of challenges I'm not going to deal with in my talk today. So I'm just going to assume I have at least good information on patients' baseline covariates. And then I additionally have information N, which represents their utilization intensity. So there are lots of different ways that you could try to quantify this. I'm going to assume that we look at some fixed window around baseline and count up how many visits the patient made to the healthcare system. And we're going to use that as a measure of their utilization intensity. So this is based on work by my former postdoc, Molly Zhang, which was published in Epidemiology earlier this year. And the really nice contribution that Molly made in this paper is to think through really, really carefully a taxonomy for how we can describe the relationships among these variables and when they will result in bias due to each of the two different mechanisms that I've described here. So the real study that this was motivated from is using data from the Flatiron Health Oncology EHR database. So this is a national database including a very large number of cancer patients and cancer clinics. The majority are community cancer clinics, not academic practices. So the data that we get really looks like what real-world cancer care looks like and what real-world outcomes look like in cancer patients. So using this data set of real-world EHR data, we wanted to see whether or not it was possible to look at the relationship between a comorbid condition like diabetes and a challenging to ascertain an EHR outcome like real-world progression or death, and try to quantify how much bias would be induced due to the informative observation challenges that I've been describing. I really, really like directed acyclic graphs or DAGs. I use them to inform my decision-making about how to conduct statistical analyses all the time. So I'm going to show you first this DAG, which describes what we think are the set of relationships that are relevant in this real-world study. And then I'm going to take you through the taxonomy that Molly developed and show you kind of in the abstract how the presence or absence of different sets of these relationships induce bias in different ways. So here, what we want to learn about is the relationship between diabetes and progression-free survival. As I said a minute ago, we don't have perfect information on either that exposure or that outcome. So what we do have is something like a diabetes ICD code, let's say, and this real-world progression or death variable that's derived from EHR. So we want to estimate the red arrow here, but we're instead going to be estimating the red arrow between the EHR imperfect realizations of those two variables. We assume that there's differences in healthcare utilization across patients, and those differences in utilization could be driven by the exposure. So patients with more comorbid conditions tend to have more healthcare utilization. They could also be driven by the outcome of interest. So a patient who's experiencing cancer progression is going to have a whole host of symptoms, which might lead them to have more healthcare utilization. But then additionally, and somewhat problematically, utilization intensity is also going to influence our ability to correctly capture the exposure and interest that exposure and outcome that we're interested in. So the more you visit the healthcare system, the more likely it is that you're going to have ICD codes for your comorbid conditions recorded. So utilization intensity potentially drives capture of the exposure. And similarly, for something like progression, which is really tricky to ascertain in EHR, we can't ascertain progression unless you have radiologic scans or physician's notes that tell us that you've experienced a progression event. So patients who make more visits to the healthcare system are more likely to have a scan, for instance, that allows us to pick up the fact that they've experienced progression. So I'm going to break down these relationships into three different types. The first is the case where we have non-differential misclassification, and that non-differential misclassification can be either independent or dependent. So in the two DAGs that I have here, there are no arrows between X or Y and N. So in this setting, the true underlying conditions are not driving utilization intensity. However, utilization intensity is driving either just X, our ascertainment of X on the left, or ascertainment of both X and Y on the right. The reason that this is important is if we knew that the misclassification mechanism was non-differential and independent, then we would know that any bias in our estimate of the association between XO and YO is just bias to the null. However, if we have either differential misclassification or dependent misclassification, then the bias can go in any direction. So we don't know that our result is necessarily an underestimate. It in fact could be biased in any way, and it's impossible to predict. So in this setting where we know that the misclassification is non-differential and we're just uncertain whether it's dependent or independent, if we condition on utilization intensity, so that could consist of, for instance, including N in a regression model when we're assessing the association between XO and YO. If we condition on N, then that converts the non-differential dependent misclassification mechanism to a non-differential independent misclassification mechanism. So it essentially breaks the confounding of XO, YO by N. In a second, more complicated setting, if we think that capture of XO and YO, if we think that X or Y drive N, so if we think that the underlying exposure or outcome influence the magnitude of utilization, then we have either differential independent misclassification on the left or differential dependent misclassification on the right. So this is problematic because under either of these mechanisms, we now have bias that could be conservative or anti-conservative. We don't know. So I would argue that if you're doing analysis and you're thinking through these issues, you want to make a DAG like this, and think about which relationships are plausible. But I think you're going to end up in a case where you think that this is plausible very often, because we know that people visit the healthcare system because they're sick. So it's going to be very often the case that the true underlying exposure or outcome drives utilization intensity. The good news is, in this setting, we could do the exact same thing we did in the previous setting. We condition on N, utilization intensity, and that converts both of these misclassification mechanisms to non-differential independent misclassification. So again, we're back to the setting of bias towards the null. The most problematic setting is this third one, where we think both the underlying true exposure and the underlying true outcome influence utilization intensity. So if that's the case, again, we have differential independent or differential dependent misclassification. However, here, when we condition on N, it actually induces a new bias. So this type of bias is referred to as collider bias. It arises when you condition on the common effect of an exposure and an outcome. So by conditioning on N in this setting, we induce a new spurious association between X and Y, which creates a new backdoor pathway between XO and YO, which means new bias between XO and YO. So here we're trying to fix the problem by adjusting for utilization intensity, but we've actually made it worse. I would strongly suspect that this is the situation that we have in the real breast cancer and diabetes example. I think it's very likely that both the comorbid conditions and cancer progression influence healthcare utilization. So it's been previously argued in literature on informative presence bias that in many settings, it's safe to just condition on N. I would argue that I don't think that it is, at least not as a blanket solution, unless you have strong reason to believe that this sort of collider bias set of relationships is impossible. I would definitely not just condition on N and assume that the problem is solved, but I think you have to go another step.
I have a question.
Sure.
Sorry, are you taking? Oh yeah.
Yeah, go for it.
I mean, is it safe to say that the collider bias is just more likely to happen when you're looking at the X and the Y are themselves like diseases that could cause high utilization? So, for example, this cancer example you gave, and so it's kind of like the more that it's likely that that's going to cause that utilization, actually, the less likely you should be to try and adjust for it. Is that kind of the message I'm taking away from that slide? Is that correct to say?
Yeah, I think that's correct. It's a little challenging because I feel like when you think these things through, you can kind of come up with a story for why almost anything is related to almost anything else. I definitely agree with the statement that you made that if X is a health condition, it's going to be really likely that there's a relationship between X and N. If it's not a health condition, that might be less likely. But there are going to be a lot of patient characteristics that are associated with healthcare utilization for, through one mechanism or another. Or I was thinking about, there's a lot of interest in, for instance, drug repurposing. So we might be interested in whether like a statin is associated with cancer progression, in which case X might be a medication exposure, but those are also going to be related to health and therefore also going to be related to utilization. So you kind of have to think it through on a case-by-case basis and think about what's plausible, because you can't always come up with a story for why hypothetically two things might be related. And sometimes those stories, like you have to, it's a pretty big stretch. Like it's a pretty outlandish kind of story to really convince yourself of that. But I think it's worth doing the sensitivity analysis, the quantitative bias analysis that I'm going to talk about next, if you have like any suspicion that this might be the case, just to try to reassure yourself that your results are robust to this kind of bias.
That's very helpful. Thank you.
So the quantitative bias analysis approach, which you can undertake to get a sense of how much your results are being influenced by these informative presence issues, is quite straightforward to implement. I'm a big fan of things that can be done with standard software that don't require some kind of new code. You don't have to come up with a new R package. You can just use things that are already out there in a pretty straightforward way. So the idea behind this is, If we take our data and each observation in the data set, we replicate 4 times, and each of those replicates we set to one of the possible combinations of XO and YO. So there are 4 possible values, 1, 1, 1, 0, 0, 1, 0, 0, right? So those are the 4 possible combinations that X and Y can take. And we're going to set each of our replicates to one of those. So each person in the data set now contributes an observation with each possible combination of exposure and outcome. We're then going to weight each of those replicates by the probability that that is the true exposure and outcome of that patient, which we will derive from the sensitivity and specificity of XO and YO. Once we have this sort of quadruply multiplied and weighted data set, we can just analyze it using standard weighted regression approaches like weighted generalized linear models, weighted logistic regression. And the result that we get will be an unbiased estimate of the parameter of interest if our weights are correct. So if we actually know what the probability of that X and Y are, conditional on the observed XO and YO and utilization intensity and baseline covariance. In practice, that is not information that we will ever have. Hopefully, we're using exposures and outcomes that come from some kind of a validated algorithm that somebody has established the operating characteristics of. So it's definitely best practices when analyzing EHR data to use X's and Y's with known operating characteristics. But this algorithm is saying we not only need to know the sensitivity and specificity of X and Y separately, but we need to know the sensitivity and specificity of each of them conditional on utilization intensity, and we need to know the sensitivity and specificity of one of them conditional on the other. So what's the sensitivity of X conditional on Y, or what's the sensitivity of Y conditional on X? In practice, no one has that information. That validation study has never been conducted. You're never going to know all of those pieces of information that you would need to. So rather than using this as a analytic approach that's going to be your primary analysis, I would argue that this is a good candidate for a quantitative bias analysis because we can vary those sensitivities and specificities across plausible ranges and see if across the plausible range our results are qualitatively different. So if they're pretty much stable, then we can conclude that our findings are robust to this to these sources of bias. If they vary and we'd come to a different conclusion, then we have to interpret our results with a grain of salt because we know that they may be influenced by bias due to informative presence. These are results of a simulation study that are just demonstrating at a very high level that you get bias if you ignore this problem or if you just adjust for utilization intensity. And you can remove that bias if you knew those sensitivities and specificities that I mentioned on the previous slide and use the weighted regression approach that I described. So across the panels here, I'm showing a series of different misclassification mechanisms, the non-differential independent, non-differential dependent, and so on. The main takeaways that I want to impart from this, just at a very high level, are firstly that the covariate adjusted approach, which here is called COVAR, does not reliably remove the bias. Even in settings where it's converting bias to non-differential and independent successfully, we still get bias towards the null. So compared to the true association, we still have a biased estimate. The other point that I want to make is the blue plot, which is the results of the predictive value weighting approach. Those results remove the bias. They're successfully centered around 0, the non-bias, the no bias line, when we know the sensitivities and specificities that we need to know. However, they have a lot of uncertainty. So you can see that the error bars are much bigger than we get from the naive approach that ignores the problem or the covariate adjusted approach. So you can think of that as either a feature or a bug. I'm going to argue that it's a feature because we're doing an analysis in which we have both an outcome and an exposure that we don't really know. We're making our best guess based on EHR data, but we know that guess has error in it. So it's appropriate that there should be a pretty large degree of uncertainty in our estimates. So the blue bars here are appropriately representing our uncertainty, incorporating the fact that we don't truly know either X or Y. And the naive and covariate adjusted approaches are both really underestimating uncertainty because they're failing to account for the fact that we don't really have perfect information on our outcome and exposure. But those are those are very stylized hypothetical results because in practice, we're never going to have all of the operating characteristics that we need to plug into our calculation of the weights. So what we need to do is a quantitative bias analysis, and this is an example of part of what that looked like for the study of the relationship between diabetes and progression-free survival. So in that study, the true, the empirically observed odds ratio was 1.09. So when we just dumped it into a logistic regression model and looked at the association between cancer progression or death and having diabetes, we saw that patients with diabetes had increased odds of cancer progression or death. When we adjusted for utilization intensity around baseline, that was attenuated a little bit, but in both cases, we ended up with a small positive association. What I'm showing in the heat map here is the point estimate that we get from the quantitative bias analysis approach as we vary the magnitude of the sensitivity of X and the sensitivity of Y for individuals who we put into a low utilizer class. So in order to facilitate this quantitative bias analysis, you have to make some assumptions about discretizing utilization intensity. In this example, we just split it into two classes, high utilizers and low utilizers. And here I'm varying sensitivity of X and Y for low utilizers while I hold it constant for high utilizers. So what I would do in practice in a real analysis like this is plot these results, take a look, and what I'm looking for is regions of the figure where I'd come to a qualitatively different conclusion using the weighted value than I did in my original empirical analysis. So in this case, in settings where the sensitivity of Y in my low utilizer class is 1, that's the top row of this figure. I see here that the direction of my association, my estimated association is reversed. So I see a small negative association. So that means if that's a range of sensitivity that I think is actually plausible, I would have concern that this suggests my results are not robust to informative presence bias. In this case, in the real application, we felt that the probability that the sensitivity of Y is perfect in patients who are low utilizers was very, very low. So this first row is probably outside the range of plausible relationships. And across all the other values that we looked at, we saw you'd come to the same conclusion, that there's somewhere between a small positive and a moderately large positive association between diabetes and cancer progression or death. So in the last part of my talk, I'm just going to quickly touch on how these issues kind of propagate forward into personalized medicine and personalized risk prediction. Personalized medicine is super popular right now. For obvious reasons, it would be preferable if each individual patient received care that was tailored to their specific needs. In practice, this often takes the form of having medical practices or decisions or interventions that are tailored based on a risk prediction model. I'm going to show you results that are specifically grounded in the context of cancer screening. So in cancer screening right now, for instance, for breast cancer, all women over a certain age are recommended to get annual mammography, or depending on who you ask, maybe every other year mammography. But it's not a tailored recommendation. It's a one-size-fits-all recommendation. An alternative approach would be to develop a risk prediction model which identifies women who are at high risk of cancer or at high risk of having mammography perform poorly. And then for those individuals, we would say either you should get screened more frequently or you should be screened with a modality other than mammography. However, for all the reasons that I've been talking about up to this point, we know that data quality is not the same for all people. And so the risk prediction models that we've generated do not necessarily perform the same for all people, and in particular, may perform differently across racial and ethnic groups for a whole host of reasons. Those include just demographic underrepresentation in the data sets that were used to develop the risk models, use of genetic information that may have been derived in populations who are primarily of European ancestry. Most relevant to the data quality stuff that I'm worried about, historical patterns of inequitable care and outcomes that propagates into systematically poorer data quality for underserved populations. So yeah, for all the reasons I've already been talking about, we think maybe their exposure information is poor, their outcome information is poor, the quality of personalized risk prediction that we're able to generate is potentially poorer. So I worked with researchers from the Breast Cancer Surveillance Consortium, which is a large national consortium that brings together EHR data from radiology facilities on breast screening and cancer registries on cancer outcomes to look at utilization, performance, and risk prediction for women undergoing mammography or other modalities of breast cancer screening. The reason I think this is really important is that developing these personalized risk prediction models has almost immediate policy implications. So with the Breast Cancer Surveillance Consortium, we were interested in identifying women who are at high risk for having a second cancer missed by mammography. So the idea here is mammography works well for women with no history of breast cancer. For women who've already had cancer once, we want to continue to surveil them to see if the cancer comes back or if they have a second cancer. Mammography does not work as well in that population with a personal history of breast cancer. So if we could identify women in that cohort who are at high risk for having their cancer missed by a mammogram, then we could triage them to a more sensitive modality like MRI. So if we develop a risk prediction model for women who are likely to have mammography perform poorly, and that gets picked up by professional society recommendations or the US Preventive Services Task Force, that immediately has implications for access to a resource in the form of MRI, because women who are at high risk are going to be approved for that additional screening, and women who are estimated to be at low risk are not. So we developed a risk prediction model for what we call surveillance failure, so having a second breast cancer missed by a mammogram. And when we did this, we were particularly interested in thinking about issues of algorithmic fairness and ensuring that the performance of this model was similar across all race and ethnicity groups. In the interest of time, I'm going to skip over the details of this modeling. I think I'll just show you a couple results. One point I'll make is, even though the data set for this consortium is huge, it includes millions of women, millions of mammograms, when we drill down to the population of interest, we end up with small data set, particularly for minoritized race and ethnicity groups. So you can see a very few Black, Asian, Hispanic, or other race and ethnicity patients. When we look at performance of the models across race and ethnicity, so this is showing 3 different measures of calibration across race and ethnicity groups for a suite of different models that we investigated. The main thing that we found was the models that were well calibrated in the full population were well calibrated within all of the race and ethnicity subgroups we were able to look at. However, we could only look at 3, just Asian Pacific Islander, Black, and non-Hispanic white, because demographically the other groups were too small for us to come up with any kind of reasonable estimate. So we immediately have a problem just due to small sample sizes. Additionally, if we believe that there are differential data quality issues, so we think that we may be systematically less likely to have good cancer ascertainment for women from underrepresented groups, then I don't trust these calibration results anyway, because it may look like our model is performing well, but it's only performing well with respect to the imperfect data that we have collected. So to try to get a handle on that issue, we conducted a simulation study where we used the real BCSC data as inputs and then simulated downstream outcome data, either allowing for or removing relationships between race and ethnicity and downstream cancer characteristics and mammography outcomes. So the idea was that if we could sort of knock out some of these relationships between race and ethnicity and downstream outcomes, we could get a handle on the extent to which being from a underrepresented group influences the performance of these models. In specific, we developed a cancer risk prediction model and a surveillance mammography failure risk model that did not explicitly include race and ethnicity. So race was not a predictor in the model. But even so, even using a ostensibly race-blind model, we still see trickle-down effects on mammography performance. So just to illustrate that quickly, I'll show you this one result. So here what we did was to simulate data where we allowed cancer characteristics to vary according by race, allowed social determinants of health and cancer characteristics to vary by race, or introduced differences in data quality that were differential by race. And then we looked at the proportion of women from each race and ethnicity group who would be recommended to receive supplemental imaging based on our personalized risk prediction model. What you can see is across the board, Black women were far more likely to receive a supplemental imaging recommendation than any other group. In this setting, the data quality issues did not seem to influence that much, so that's sort of reassuring considering our earlier results. But we see a really strong relationship between social determinants of health and race, which results in this really dramatically higher supplemental imaging recommendation among Black women than women of other races. So when I look at these results, the conclusions that I take away are that even a risk model that doesn't include race leads to inequitable medical decision-making, but it doesn't necessarily lead to unfair medical decision-making. We see big differences across race, but perhaps those differences are appropriate given differences in the underlying risk distribution of different groups, differences in cancer prognosis, and so on. So the next steps in this work are really to take this and think about what the implications of these personalized risk prediction models are for cancer outcomes. So if we were to screen at these rates that are different by race and ethnicity, does that lead to equitable or inequitable outcomes in terms of second cancer diagnoses and cancer mortality? Okay, I'm running out of time, so I will wrap up quickly, which just to say that I think there's a lot of potential for research conducted in EHR, but there are many methodological challenges because the data are very messy and in many ways do not look like traditional research data. So I love this as kind of a proving ground for data science because we need all of the disciplines that make up data science in order to do a good job. If we don't think about where the data came from, how they were generated, what clinical practice looks like, what coding practices look like, we're not going to be able to account for these issues and get to a correct answer. And I think I would just reiterate the importance of understanding where the data came from, thinking about how our research is going to influence policy and practice, and working together interdisciplinarily to try to do the best research that we can possibly do. My XKCD figure on the right-hand side of this slide, I'm trying to draw attention to the fact that there are many things we can do that seem very exciting and fancy. Using EHR data is exciting. It potentially gives great results, but just because it's new, just because it's cool and shiny does not mean that the result is necessarily correct. I think we have to think really carefully about how we do this research to make sure that we are not producing erroneous results. And I will wrap up there with 1 minute to spare. Thank you.
Thank you so much. I think we have a question in the chat from Pooja. Pooja, do you want to unmute yourself and say the question?
Sure. Can you hear me?
Yep.
Okay, cool. Sorry, we're in a conference room and hoping all the mics and stuff work. First of all, thank you so much for a great talk. I was really struck by so many of the different things, specifically around this as we're chatting about it. Just for context, I'm someone who works more on the interaction side of things, thinking about how do we communicate some of this information directly to patients and medical providers as we deploy risk models into care and various other systems into care. And so one of the things that we were wondering as you were talking about this was, there's so much about this, particularly as models continue to be sort of in a place where they can be deployed into care, specifically in these use cases that you were talking about towards the end around precision medicine, but also, as they're deployed into care with like the 21st Century Cures Act, where patients are seeing this more and more. And one of the questions I was kind of wondering as you were talking about this was, what do you think is sort of the most important? It's a very general question, but most important for non-informatics oriented medical professionals and patients, or non-informatics oriented medical professionals, when they use these models to make decisions, and for patients to understand about some of these underlying data bias and fairness issues, because I think there's a lot of emerging work within informatics, and we're starting to tap into this, but at the same time, we're in this moment where communication to the patient is also an important part of closing equity gaps. And I'm curious what your thoughts are about this and what your experience with this has been so far.
I think that's a really good question, and I can tell you what I think is important, but I don't have the answers. I don't have the solutions to this because I think it's a bit outside of the things that I really know about. From a communication, I think communication is huge. I think like we saw that during the pandemic. Communication, you can have the best model in the world if you don't know how to communicate it in a way that's going to be accessible to patients. It's sort of irrelevant. So what I think we really need, and I don't know how to do this, but I think it's really, really important, is better communication with the general public about uncertainty. Risk prediction is obviously not an exact science. We aren't able to assign everyone like a 0 or a 1. We're not prognosticators. We don't know what's going to happen in the future. We're just taking our best guess based on the available information. And somehow communicating that uncertainty, the uncertainty in these models is super important. And also thinking about the kind of data bias issue, communicating that this attempt at personalization is our best attempt, but you should think about, and in communication and consultation with your physician, think about what makes most sense for you as an individual. Like part of the discussion I've seen around race and including race in risk prediction models is race is kind of a poor proxy for a lot of different things. It's very messy. We don't know what it really means. Sometimes people want to use it as a poor proxy for genetics. Sometimes people want to use it as a poor proxy for social determinants of health. But it's this like poor construct that doesn't really reflect anything. And so, I think about what I would do if I were in a medical decision-making situation, and as a Black woman, someone's giving me the risk prediction, number that's been tailored to Black women. I would think about like, well, to what extent do I think this is meaningful for me? Or to what extent do I think my risk factors, my constellation of risk factors may be different or the same, and what is my personal family history and that kind of stuff. But getting people to maintain confidence in research and evidence while also telling them to be skeptical and think critically about the fact that our research is imperfect and has uncertainty is like walking a knife's edge that I personally don't know how to do, although I think that it's incredibly important and valuable.